this is HBV treatment algorithm. Now as per this chart, you do serological testing first. So you do HB surface antigen testing. So you can do single RDT or lab immunoassay. Now there can be two possibilities. One is HB-SAG comes reactive. In that case, it's confirmed active or chronic HBV infection. So it can be either active or it can be either chronic infection, hepatitis B virus infection. But if it comes non-reactive, so there is no serological evidence of infection. So patients with unexplained ALT elevation, there is fatigue or HCC signs, think hidden HBV infection. So test HB-SAG. Now after that, you assess the stage of liver disease. You use clinical, you use biochemical, and you use radiological parameters. Now platelet count less than 150,000, fibroscan, for example APRI greater than 1 or TE greater than 8 kPa, it's suggestive of fibrosis. Or there's a tip, that is platelets are your poor man's fibroscan. So low platelet with elevated ALT, suspect advanced liver disease. So in a patient with hepatitis B virus plus low platelet, so it's cirrhosis until proven otherwise. So if a patient has cirrhosis, so what is this HBV DNA quantification? This is the treatment decision point. So if patient is in cirrhosis and patient has HBV DNA virus, any level, and ALT of any level, you have to treat even if ALT is normal. But if patient does not have cirrhosis, then there are two possibilities. Patient's HBV DNA is more than 2000 international units per ml and ALT is greater than upper limit of normal, you treat. But if patient is not in cirrhosis, HBV DNA is less than 2000 international units per ml, ALT is normal, you just observe and monitor. So as per Harrison 22nd and EASL criteria, HBV DNA is the strongest predictor of hepatocellular carcinoma. Even normal ALT with high DNA, patient is in immune tolerant phase, you just have to monitor but don't ignore. So strongest predictor of hepatocellular carcinoma is HBV DNA, even with normal ALT. And in these cases, you initiate antiviral therapies. One is patient is cirrhotic and patient has HBV DNA or ALT of any level, you treat with antivirals. And if a patient is not cirrhotic, you see HBV DNA, if it is greater than 2000 international units per ml or ALT is more than upper limit normal, you will still treat with antivirals. So entecavir and tenofovir are the drugs that we use. Preferred is tenofovir, TAF, alafenamide, tenofovir alafenamide, for renal and bone safety. So you avoid tenofovir DF in CKD or in osteoporosis patients. And on the contrary, this DF, tenofovir DF, so we have two tenofovir, one is TAF, another is TDF. You will give this tenofovir DF in pregnancy patients, whereas tenofovir alafenamide is to be given in patients with who have renal issues like CKD or who have this osteoporosis. And what will you monitor? Monitoring is to be done for HCC screening, that is to be done every 6 monthly. And who are those? One is cirrhotic patients and another is patients having family history of HCC. And how will you monitor? You will do USG plus AFP, but USG is the best single tool to detect hepatocellular carcinoma early. And disease progression or treatment response, you will assess yearly. You will check HBV DNA, you will check ALT, HB, EAG, HB-SAG, and APRI or fibroscan for fibrosis progression. And you will do toxicity monitoring yearly. That's you will see creatine phosphate in case of tenofovir, creatine and phosphate, and you will assess renal function, bone mineral testing. So Following are the clinical scenarios. One is HbSAg positive with ALT increased and DNA greater than 2000, you will start treatment. HbSAg positive with cirrhosis, treat regardless of DNA. HBV carrier, low DNA, ALT normal, so you will monitor every 6 to 12 monthly. But if pregnant HbSAg positive, you will start tenofovir after 28 weeks if DNA is high. So treat HBV like a slow silent killer. Always screen liver stats even if ALT is normal. If cirrhosis, treat without delay. Don't wait for symptoms because HBV progresses silently. Don't chase ALT, chase DNA and fibrosis. So cirrhosis means call to action. 2000 DNA plus ALT increased, launch attack. If no ALT rise, no DNA, watch and wait. So as per Lancet Gastrohepatology 2023, HBV patients with normal ALT can still harbor inflammation or fibrosis. Don't rely on ALT alone. Because as we have seen in non-cirrhotic patients, ALT can be normal or ALT might be increased, but look towards this HBV DNA. And as per EASL guidelines 2022, fibroscan greater than 8 kPa plus DNA more than 2000 is a candidate for therapy even if ALT is normal. As per Harrison 22nd edition, new antivirals and drug trial may offer HBV cure. Now so see patterns. Cirrhosis means you have to treat. So hepatitis B virus HbSAg positive and you saw cirrhosis, treat. And if there is no cirrhosis, DNA more than 2000, ALT increased, treat. And you have to anticipate complications, hepatocellular carcinoma, CKD from drugs resistance. And one thing is if HbSAg is positive for greater than 6 months, we know that HbSAg positive means acute or chronic infection, but if HbSAg positive for greater than 6 months, then it means patient is having chronic hepatitis B infection. And you will see this in pre-surgery screenings, blood donor units, pregnant women, unexplained cirrhosis, OPD with mild ALT raise. So best initial screening is HbSAg, although you may miss this window period, whereas anti-HBC IgM is seen in acute settings and it's not needed for chronic follow-up. Anti-HBs means immunity but not useful during active infection. So how will you stage liver damage? How much liver is hurt on this? What do we do? What do we mean by this APRI, KPA in this TE in fibroscans? One is APRI. This APRI, this is AST to platelet ratio index. So how do we get this APRI? So this APRI is simply what you do is you do AST divided by upper limit normal of AST. So this is AST of patient, and you multiply it with 100 divided by platelet count, which is 10 raised power 9 per liter. So platelet count, if the value comes more than 1.5 suggests significant fibrosis, and if it is greater than 2.0 then it's likely cirrhosis, and if less than 0.5 then it is fibrosis unlikely. So low platelet means platelet portal hypertension, fibrosis, simply, elegant and direct flow. Why is this APRI used? Because it's cheap, it only needs 2 blood tests, that's CBC and LFT, and it's good for rural and OPD sites. Limitations, it's not very accurate, it's affected by hemolysis, alcohol, etc. And another is FIB4 index. So this FIB4 index, this is used in Harrison 22nd edition. So this is FIB4 index. So how do we calculate this? We calculate this age multiplied by AST divided by platelet counts multiplied by under root of ALT. This is FIB4 index. So if it is greater than 3.25, this means advanced fibrosis, but less than 1.45, it excludes fibrosis. So this is great tool in HIV, hepatitis B virus co-infection, or in transplant units, or in OPD patients. Another is fibroscan, that is transient elastography. So fibroscan is also called as transient elastography. This is the echo for liver stiffness, like a sonar gun firing waves to assess fibrosis. Output is given in kilopascal, that is kPa, kilopascal. So kilopascal less than 6 means normal liver. So where will I write this? So less than 6 kilopascal means normal liver. So 7 to 8 means mild fibrosis. Greater or equal to 8 means significant fibrosis, that is F2 or more staging. But greater than 12.5 to 14 means patient has landed up in cirrhosis. So in NAFLD or hepatitis B virus, we use TE, that is fibroscan. If it is greater than 8 kilopascal, that means the patient has landed up in advanced cirrhosis. And so ALT, if ALT is raised persistently, it means ongoing liver cell injury. If ALT is greater than 2 times upper limit normal, then you should do this. You should go by this more aggressive approach. So hepatitis B virus DNA quantification, that's viral replication. If it is greater than 2000, so HBV DNA levels greater than 2000 international current, this is significant viremia, means non-cirrhotic patient. If greater than 20,000, then it is meaning what? It is threshold in HBeAg positive patients. Any detectable DNA in cirrhotic patients, you have to treat aggressively. So what are the various scenarios this treatment decision hacks? Patient with cirrhosis plus HBV DNA greater than 0, so you always treat, because this prevents decompensation. Non-cirrhosis with DNA greater than 2000 plus ALT increased, you will still treat, because reason being there is active viral replication going on and liver injury, so you have to treat. But DNA less than 2000 plus ALT normally don't treat, it is an inactive carrier state. So treat the virus plus injury plus fibrosis, not just HBsAg positivity. So finally, monitoring phase. So hepatitis HCC surveillance, you will do USG plus AFP every 6 monthly. It detects cancer early. Treatment response, you assess DNA levels plus ALT. So DNA levels plus ALT you will assess to check suppression, because if DNA level comes down, ALT level comes down, even if HBsAg comes positive, this is inactive carrier state. So toxicity monitoring with tenofovir, you assess renal functions 12 monthly. So best tool to detect HCC early is USG, even for non-cirrhotic but high risk cases, for example patients having familial HCC. So as per Harrison 22nd edition, Chapter 204, fibroscan is an accurate, non-invasive alternative to biopsy for fibrosis staging in chronic HBV, especially with ALT less than 5 times upper limit normal. And as per Lancet Gastroenterology Hepatology 2023, APRI and FIB4 can reliably exclude advanced fibrosis in resource-limited settings. And as per Brown-Walton, HBV-induced HCC, HBV integrates into host DNA leading to HCC even in absence of cirrhosis. Why lifelong monitoring is crucial even after viral suppression? That is because of this. So don't just chase lab reports, recognize patterns, and don't just treat viruses. You have to stage the battlefield and protect the organ. So that's how you will save lives before they rot. Thanks, and subscribe.